Hey everybody, it's Dr. Wood, and we're going to continue on talking about our second half of the OB-GYN section here. So we're getting into our estrogens and progestins. We're going to mainly be focusing on a lot of things like hormone replacement therapy, and then we'll also talk about contraceptive use and a few other sort of miscellaneous things we can use for these patients here. So first starting out, let's look at the actual normal physiology of the system here. We're going to see this is a pretty typical feedback loop like we have seen previously. We have things like GnRH. They'll be stimulating release from the hypothalamus, getting released onto the anterior pituitary, which then stimulates the secretion of things like luteinizing hormone and follicle stimulating hormone. We know these are going to have positive effects on the ovaries, and we'll look at some of the other changes we're going to see there during the typical menstrual cycle. But ultimately what we're going to find being released during this cycle is estradiol and then progesterone. These are kind of the two main components we're going to be talking about. Now, this is a negative feedback loop, meaning once levels of estradiol and progesterone, once they increase, you're going to see that they can then feed back and actually have negative effects here. So for the most part, this will be a negative effect where estradiol will be released, and that kind of tells the hypothalamus and the anterior pituitary, we have enough stuff here, we have enough of the final product, go ahead and shut down further production. So there's ways that we can try to manipulate this. So for instance, we can try to shut the system down sort of artificially by giving things that take the place of estradiol. So that would be the case of something like our hormonal contraceptives that we try to use to help shut down ovulation from occurring within the ovaries. We can either do that with a combination of estradiol plus progesterone, or we might even see progesterone by itself. Or we may just want to replace maybe what a patient isn't producing on their own. Say, for instance, their ovaries are not producing estradiol anymore. We can then replace that potentially. So here are the other changes that occur as a result of the release of LH and FSH, and then some of the changes you're going to see in your estrogen and progesterone production. And so you can kind of see how this all lines up together. Typical menstrual cycle is roughly 28 days, although we know that can be variable depending on the patient. But kind of the couple different things you want to look at, including the follicular development, which actually occurs. This is when ovulation actually happens, when you actually have the egg being released to then travel through the ovarian tract in order to get ready for implantation and conception potentially. We'll see that the endometrium has to be developed here as well in order to make it to be a nice hospitable environment for a potential egg to be fertilized potentially. But those are typically occurring right in this around 14 days or so into the cycles when this ovulation actually occurs. Now, what stimulates this to occur in the first place? Well, a lot of it has to do with the LH and FSH levels, right? So you'll typically see that levels will be pretty consistent throughout the first 2 weeks or so, and then you get what they call the LH surge, and that happens around day 14, and this actually kicks off the whole ovulation, the event itself, right? So you have this big surge, and then levels then drop down fairly low, right, as a result of the fact that you're having more estradiol being released as a result of this coming from the ovary, right? Because a lot of these, the major follicle and then eventually the corpus luteum will be generating a lot of those hormones, and then you'll finally realize that as you get into the sort of the final week here, is where progesterone levels are then going to start to tick up. And so again, this is the whole cycle will then start all over again, assuming actual pregnancy or conception does not take place. And so you can see that when we talk about things like hormonal replacement or hormonal contraception, we may talk about things like triphasic or biphasic, and all that has to do with how closely the drugs are actually mimicking what the natural changes in the hormonal content are of the products here. So we'll get more into that when we get into specific products later on, but that's essentially what we're trying to see, is how well can we sort of mimic what's naturally occurring here anyway when we're trying to give these medications. So we know that this is a common problem, these disturbances in ovarian function for a lot of female patients that come in here. And it could be due to a lot of things, right? So maybe you have some kind of cancerous process, maybe it has to do with inflammation. We even know things like, diet and exercise can have some effects on things like GnRH secretion, right? So we know that like high level athletes, for instance, don't typically menstruate very regularly because of the fact that their bodies are in kind of a chronic sort of athletic sort of state where the body's not really all that interested in potentially getting pregnant. And so different things like that, I just use that as an example, but lots of other cases where things like severe physical or emotional stress can also have pretty significant function or effects on the overall function of this system here. So getting into the major estrogens that we produce ourselves. So estradiol is going to be a major one, and this is going to be the main thing that comes out of the ovaries. You will also have some sort of secondary ones, which we probably won't talk about too much during this talk today, including estrone and then estriol. These actually come about from conversion in the liver or like in the peripheral tissues. These are going to be less clinically relevant for our purposes today. But what's interesting is you can even have, other animal sources actually having they can look similar enough to our bodies to where they can actually be a decent replacement. So just like we used to use bovine and porcine insulin, well, we can actually use things like equine estrogens. And so equine obviously comes from horses, and so we had things like equilin and equilin. And this actually used to be one of the big ways that we would give hormone replacement therapies, by using these equine estrogens. And how they would actually produce them is that they would actually have these mares that would be pregnant, and they would be producing just large amounts of estrogens, and they would release that. Some of it should be released out into the urine. And they can then collect that and then purify it. And so that's where we have Premarin comes from pregnant mare urine, right? So I always like to point out the interesting places where we get some of our medications, though. That's another one there. So looking at how we actually produce it ourselves, I don't have the horse picture up here, but I'm sure you can find that somewhere in a veterinarian textbook perhaps. But anyway, what we're seeing is that, a lot of the hormones that we produce have common sort of ancestors, so to speak, some common antecedents in terms of where they're being produced from. And so here's an example here. We have androstenedione, how this can eventually be turned into a lot of different hormones. So for instance, it can undergo conversion into something like testosterone, for instance. But one of the big enzymes I want to focus on here is actually aromatase, where you can see that this helps to convert testosterone, this is the main one to focus on, into estradiol. This is the main one we mentioned as having kind of the most estrogenic effect in our patients. And so again, they can then be interconverted into a lot of other products like estriol and estrone, like we mentioned previously. But this is the main thing I want to focus on, and this is going to be a main way we can interact with the system as well. So say for instance we want to drop down levels of estrogen production pretty significantly, well, I can inhibit this aromatase enzyme. That's going to be a pretty effective way to do that. But you're going to see that when you cause imbalances in the system here, you can find that this can cause disruptions. It can cause certain products to become produced in larger quantities than normal. So as an example, if I were to inhibit the enzyme aromatase, well, basically I have all this extra testosterone sitting around here because none of it can be converted over into estradiol. So you might imagine that someone who's on an aromatase inhibitor, they may have some masculinizing sort of effects here, because it may actually help to have more testosterone activity, you have more androgen, maybe you convert more of that into DHT, and then all of the effects that we know that comes about from that. So just some examples I want you to kind of think about how, if you monkey with one aspect of the system, what does that have on maybe previous steps or downstream steps potentially. So we have a lot of synthetic estrogens we can administer to patients. So for instance, ethinyl estradiol is probably the most common one you're going to find in most like oral contraceptive products here, but there's many others that are available, and they all have pretty similar effects for the most part. Another common one you see a lot for hormonal replacement therapy. So for instance, with like your postmenopausal women, we have our conjugated estrogens, which is kind of just like a mixture of different estrogenic compounds that maybe all just kind of slap together. And so again, we're going to get into maybe not specifics on how each one of these works a little differently, but we'll kind of talk about their overall activities and overall sort of what are the dangers and the benefits and things like that. So getting into the pharmacokinetics, this is important in terms of estrogens because things that can affect the half-life or things that can affect its excretion or metabolism can have large effects in terms of what kind of side effects you can expect to see or how effective the drug might be in the first place. So for instance, we're going to see that in terms of estrogens coming in here, that yeah, it is highly protein bound, which there may be some drug interactions where you can see maybe some other drug come and kick it off the protein potentially, but we are going to find that there's a lot of metabolism that occurs with estradiol and estrogen in the liver itself. And so what's interesting is that from an excretion standpoint, a lot of these actually get conjugated with different metabolites that actually get excreted into the bile. And so you're going to find that when they get excreted into the bile, they are inactive in themselves, but they actually get hydrolyzed back into the parent compounds, usually due to things like colonic bacteria that allow it to be reabsorbed. And so I've talked about this before, but that's that enterohepatic recirculation where things will get kicked out into the bile, get reabsorbed through the GI tract, and that helps to extend the half-life of the drug and allow it to stick around for longer. This is again why we talk about patients being careful when they're on antibiotics and they're on oral contraceptives and an antibiotic, because you can end up having a disruption of that recycling and thus levels of estrogen will drop, and we can see what kind of effects that'll have down the road. Be aware though that especially when you have oral hormones coming in, that you're going to see a lot of high ratio of hepatic effects. The main reason for that is because of first pass. That's the first organ that's really going to be getting the chance to interact with those drugs. And so we're going to see what adverse effects come about from the effects of estrogen in the liver. This can be avoided though by giving it via other routes. And so sometimes we do this to help avoid a lot of those sort of hepatic and peripheral effects. So we can give it either vaginally via injection or maybe even transdermal preparations like patches and creams and things like that. So once the estrogens get into the target cells, they will then go into the nucleus. They will bind to various estrogen receptor response elements, and it will have whatever varying effects they're going to have. So for instance, if it gets down to the breast tissue, it will have a positive effects in terms of causing hypertrophy of the tissue and potentially stimulating cancer cells to replicate and things like that. In the bone, it helps to decrease osteoclast activity. In the uterus, it helps to stimulate production of uterine tissue. So there's a lot of different activities that it will have based on the tissue that you're in. This is kind of the basis for our SERMs, or the selective estrogen receptor modulators. Whereas where estradiol will act as an agonist everywhere, we can have certain drugs that may act as an agonist in one type of tissue while acting as an antagonist in other types of tissue that can be beneficial for various disease states, which we might mention a little later on. So again, this is kind of just reiterating what we already mentioned here. And again, depending on the tissue you bind with will determine what sort of different effects you can expect to see, which we'll get into in just a little bit. So what are those clinical effects of estrogens? Well, one of the big ones is going to be female growth and sexual maturation, especially around puberty. This is what helps to stimulate things like growth of secondary sex characteristics. You see changes in hair growth distribution, body fat distribution. Also, you tend to find that this epiphyseal closing will happen here around puberty due to the estrogen effects, which is why, while female patients may actually have their growth spurts a little bit earlier than male patients around puberty, you will see that ultimately their stature is shorter on average than males because they have that extra estrogen effect causing those growth plates to kind of close up a little sooner. So it's kind of an interesting thing you'll see there. Endometrial effects are really important here because estrogen helps to stimulate the endometrial lining, which is really important, say, for instance, if you wanted someone to get pregnant, right? Now, it's important that there's a balance here because if you had unchecked estrogen activity, you'd find the endometrial tissue would just continue to grow and grow and grow, which is not great because we worry about things like, cancer potentially being a risk here of having unopposed estrogen. This is why it's really important that if we have someone, especially if they have an intact uterus, that you have a progesterones being given as well, because this helps to regulate it, right? Progesterone helps to, stimulate normal regular bleeding and shedding of the endometrial lining, assuming no conception has occurred. And so you can kind of think about, estrogen being kind of like fertilizer on the endometrial tissue, whereas progesterone is kind of like a lawnmower, and it kind of helps regulate things and make sure that it doesn't get too wild, too out of check in terms of its growth. So it's kind of one way I like to think about it. And again, just like you can see here, continuous exposure to those estrogens does cause hyperplasia and eventually some abnormal bleeding. Metabolic effects you're expecting to see is that one that will help to decrease bone resorption because it actually helps to stimulate osteoclast activity to die. It helps or causes them to undergo apoptosis. It antagonizes PTH. It's a lot of different activities here. We can also see things like changes in lipid profiles, like you'll see increases in HDL and increases in triglycerides as an example. But a lot of this can be related to some of the effects in the liver, especially the cholesterol effects you're going to see there. In terms of coagulation effects, typically estrogens are going to have a positive effect on causing production of clotting factors within the liver. So not only do you see these vitamin K dependent clotting factors being enhanced in terms of increasing the number of factors being produced and released into the bloodstream, you're also going to have decreased antithrombin 3 activity. And we know this to be really important in terms of how our heparin works, because it helps to make antithrombin 3 work faster. This is going to diminish that. And that's going to feed into one of the really big warning side effects you think about when you think about estrogens, which we'll talk about in just a little bit. Other things you can find, including its effects on things like mood and libido. You may find this may be enhanced in some patients, it may be inhibited in some patients, depends on how they respond to it. And then you may also see some mineralocorticoid effects as a result of it affecting things like aldosterone receptors. This is why you can see when patients, especially during certain phases of their menstrual cycle, they can develop some weight gain associated with edema and fluid retention as a result of those mineralocorticoid effects. So how do we use estrogens? We'll use them a lot for things like primary hypogonadism. So say, for instance, someone had, say like a pituitary tumor that was resected and you needed to replace those estrogens that now they can no longer produce. I saw that quite a bit in especially like patients, if you ever go to the School for the Deaf and Blind in St. Augustine, there was a lot of patients who the reason they were blind is because of these pituitary tumors and things that they would get. They had to have resected that ended up affecting the optic nerve as well. So not only did they have to worry about things like, hormone production, but, also their vision was affected and all kinds of things. And so typically when we end up administering this, it would be around when they would normally undergo puberty anyway. It does help with making sure that we stimulate those secondary sex characteristics, they menstruate normally, and it can help to prevent osteoporosis because we do know that estrogens tend to have healthy effects on the bones, keeping them nice and strong. Typically, you'd start them off on, say, day 1 through 21, when normally estrogen would be being produced anyway during the cycle there. And then once they have their first bleeding, then you can go ahead and give them that progestin to kind of normally simulate what the normal menstrual cycle would be like. And they can just be on basically physiologic doses of estrogen and progestin from there on out, basically going on these normal cycles. And in fact, when you look at a lot of hormonal, either contraception or maybe hormone replacement therapy, you will frequently see that the first 3 weeks of pills are all going to be active drug, and frequently that last week is going to just be placebo. And you can always tell that based off the fact there'll be a different color, but you still want to recommend patients take every single pill there because it helps them to stay in that habit to make sure they don't stop missing one. Because if you told me, hey, take this for 3 weeks and then stop taking it for a week and then go back on for 3 weeks, I probably wouldn't be able to keep that straight, and I don't imagine a lot of patients would either. So another big use we're going to use this for include postmenopausal hormonal therapy. This is our HRT, or hormonal replacement therapy. This is going to be helpful for patients who have basically lost the ability for their ovaries just produce their own estrogen and progesterone anymore. This oftentimes can result in a lot of things like vasomotor symptoms or the hot flashes you think about. My mom always called them power surges, which I always liked that as being a positive sort of spin on a adverse effect of aging. But you can see things like genital atrophy, which can lead to dyspareunia or pain on sex. A lot of uncomfortable issues that can pop up as a result of estrogen depletion. Not only that, but they're going to be at risk for having osteoporosis because they're going to have accelerated bone loss because all those osteoclasts are not going to be kind of working at a higher level because they've lost that drive for apoptosis due to estrogen. Not only that, but we do see there could be some changes in atherosclerotic changes, things like increases in LDL. You can find that for a while we thought that estrogen would be cardioprotective, but we realized that due to the issues with clotting that come about from these as well, that it's probably kind of a wash. And so there's a large study there that actually showed no benefit with using estrogens as a cardioprotectant. So you're going to find that in terms of how we're administering this, in terms of what we're looking for, you want to consider what their cardiovascular history is, because it may be one of those things where it may be dangerous to the patient, especially if they have risk for clotting. Look at their risk for breast cancer, or look at their risk for endometrial cancer. There's a lot of things we'll look at in terms of things to weigh the risk versus the benefits, because these can be potentially dangerous drugs, even though they're kind of seen as like natural, because that's what our body produces anyway. They can be dangerous, right? Typically, you're going to see that transdermal and vaginal estrogen products are associated with lower risk because you don't see as many of the hepatic effects, and you help to lower sort of systemic exposure from that standpoint, especially with vaginally administered estrogens. With transdermal, it's kind of a wash because, again, it's going right into the bloodstream, but you do lose a lot of those hepatic effects, okay? And basically, when we're administering this, we're just looking to replace what they're missing, and typically the lowest dose should be used possible in order to help manage whatever symptoms tend to be most worrisome to them. So if it's their hot flashes or their sleep disturbances, use the lowest dose you can in order to help regulate that, and then I wouldn't go far above that due to some of the risks we're going to see here. This is a good caveat where it's notable that patients who still have an intact uterus, because we don't want to have unchecked growth of the endometrial tissue, those patients cannot receive estrogens alone. If they've had a history of a hysterectomy, then you don't really care about that because they don't have that uterine tissue, that endometrial tissue to stimulate. So in those cases there, those patients without intact uterus, they can receive estrogen by itself. Okay. Patients who do still have their uterus intact on the endometrial tissue, they need to receive an estrogen plus a progestin. Okay. And we'll talk more about progestins a little bit later. So other reasons why I might use this include osteoporosis. Of course, you want to make sure the calcium and vitamin D are in check, maybe get some light exercise. Really, if you think about the people who are most at risk, is typically those thin Caucasian smokers who are relatively inactive are the highest risk. And I actually had a family member who just recently had a vertebral fracture, wrist fracture, and guess what? She was thin Caucasian smoker who probably wasn't getting, she's a little bit older, postmenopausal, she just kind of fit the bill. Like, she was just an obvious risk for fracture, and guess what? It totally happened. So if they're just having vaginal symptoms, then topical preparations are going to be preferred. And again, when I say topical, I really just mean like intravaginal products. So other reasons why I might use estrogen include things like ovulation suppression, especially if they have really bad dysmenorrhea, or if we're trying to help out with things like preventing like hirsutism and amenorrhea that's associated with androgen secretion. So they have like PCOS or something like that, this can be useful. The reason why this works is because by giving estrogens, that helps to feed back on that and shut down GnRH release and LH and FSH release from the hypothalamus and anterior pituitary respectively. So by doing that, you're overall going to get a decreased amount of androgens that they're producing. Because again, we're supplying the estrogen, so the ovaries are like, well, I don't have to do anything here. There's no androgens being produced. It works out well in those situations. So adverse effects you're going to see with the estrogens, and these are numerous, but things like uterine bleeding is pretty common. Especially you always want to make sure that if a patient has explained vaginal bleeding, like you got to rule out the scary stuff like cancer and whatnot, because estrogens can make that worse, but you got to make sure they didn't have a problem to start with before you actually introduce the drug there. Again, this can be mitigated by using a relatively low dose if possible. For some patients, especially for like postmenopausal therapy, for hormone replacement therapy, you can give these consistently. You can give estrogens kind of 24/7. It's no problem there for them. There's no reason why they need that withdrawal bleeding, but some people still like to have their period, give some degree of normalcy to them, but it may also help with these withdrawal bleeding. So basically they can give it and receive the same dose of estrogen for say day 1 through 21, and then they have that withdrawal period from that last week, and they can have their normal bleeding like they would otherwise. Keep in mind though, to prevent that endometrial hyperplasia, this is why we give co-administration with the progestin. In terms of cancer risk, obviously patients who especially have a family history of estrogen-sensitive breast cancer and things like that, this is going to be a risk. So, and progestins don't do anything for this. So while progestins can prevent endometrial cancer as a result of estrogen therapy, progestins don't really help you at all with breast cancer. And so in those cases, that's why we use SERMs, things like tamoxifen, to help work as an antagonist in the breast tissue, while it may work as an agonist in, say, other tissues. As I mentioned, give progestin, prevent the endometrial issues there. And I wouldn't worry so much about this adenocarcinoma. This is kind of a rare thing that occurred back with a product called diethylstilbestrol. This is kind of interesting because it's actually maternal use. So the mom was using the drug during pregnancy, and then these women would actually get cancer, say 30, 40 years down the road. And this was pretty wild that, the epidemiologists were able to link back maternal drug exposure, something that was so far away in terms of time. So that's why they don't use DEB or diethylstilbestrol any longer. So adverse effects, common things you're going to find with estrogen therapy includes a lot of nausea, vomiting. You can see some breast tenderness, which makes sense based on the sort of anabolic effect it has on the breast tissue. You can see things like hyperpigmentation of the skin. This is a common thing, especially like oral contraceptives that may be reversible, but tend to see this happens more so with patients with darker complexions to begin with. Cholestasis, we mentioned this makes sense based off of the liver processing that happens here and it being metabolized and excreted in the bile. Things like migraines, we've looked at this before and saw that in some cases estrogens can help out with migraines, but for some patients it'll make it worse. So it just depends on the patient, how they respond to it. Hypertension can be worsened based off of fluid retention, so that's one thing to know there. And overall, you can limit some of these by using the lowest dose possible. Contraindications include if they have any sort of estrogen-dependent neoplasm. That makes pretty good sense. I mentioned the undiagnosed genital bleeding. If they have thromboembolic disorders, because it's certainly going to put them at higher risk for having a clot, especially if they're a heavy smoker. And then with liver disease, you can also end up seeing some risk for cholestasis and things like that. So those would be the things to watch out for, especially, or things you can maybe rule out, things like the undiagnosed genital bleeding, figure out what the cause for that is, and then you can maybe potentially give these patients estrogens. So progesterone is going to be the most important progestin in patients here, and it's going to be the precursor to a lot of things like estrogens and androgens and all of that. Also the adrenocortical hormones as well, so things like aldosterone, things like cortisol. This is going to be important for a lot of the side effects you're going to see here with these. And you're going to see that with synthetic progestins, there's going to be a lot more variability in terms of their mechanism of action, in terms of how they work at different receptors, than you're going to see with estrogens. I mean, estrogens kind of work like estrogens do, versus with progestin, we're going to see a little bit more variability, and I'll show you what that looks like in just a little bit. So some of the issues you're going to see with progestins is that a lot of them end up having some fairly strong androgen receptor activity, meaning they're going to be working kind of like testosterone, and then they have strong mineralocorticoid receptor effects as well, which just means it can do things like hold on to salt and water potentially. So when you see AR, that means androgen receptor. See MR, it means mineralocorticoid receptor. And so these will look familiar if you've seen any variety of oral contraceptives, but things like norgestrel and levonorgestrel, these both have pretty high androgen receptor activity. So you can see things like hirsutism, or maybe changes in voice, and acne potentially being worsened based off of the androgen receptor activity, right? Not great for some patients, but for some they may not even notice, right? It just depends on the patient. From there, you can get more variability where you have things like norethindrone, which may have more progestin receptor activity, but it's going to have less androgen receptor. So maybe getting more activity for what you're actually looking for from a progestin, versus things like desogestrel, which is going to have less androgen receptor activity, really nothing working at the estrogen receptor, and maybe have better effects on the HDL. Versus like drospirenone, which tends to be a pretty popular one because it actually has anti-mineralocorticoid effects and anti-androgen receptor effects. That could be really helpful to help with like some weight loss potentially, because you're going to be losing some fluid, and prevent a lot of androgen excessive sort of activities if they were to say have hyperandrogen activity anyway, right, for PCOS or something. So the kinetics are not going to be nearly as important for progestin as it was for the estrogens. Most of them do get, excreted into the urine, but we don't really see that same enterohepatic recycling, so it's not really going to be as big of a concern for progestins. The mechanism is exactly the same. They're going to get into their particular tissues, work on those steroid receptors, and cause whatever downstream effects it's going to be, whether it's at the androgen receptor, the mineralocorticoid receptor, wherever it happens to be at. So the effects you'd expect to see include things like not really too many effects on lipids, which is nice, but that may be dependent on looking at the androgen receptor activity to see what things you'll see there. But you may see things like increased aldosterone release as a result of it acting as a competitive antagonist at the aldosterone receptor. You may see some changes in basal insulin levels. You may actually find some changes in insulin response, which may be helpful. And you're going to find the maturation and secretory changes in the endometrium. And this is why you typically see progesterone sort of peak up during that third week of the menstrual cycle. This is to help out with those changes in the endometrium, to kind of make sure that it's kind of ready to go for implantation to actually happen. And again, a lot of synthetic agents, depending on if you're looking at one of the earlier ones versus some of the newer generation ones, they're really designed to help minimize some of the androgenic effect and help to reduce side effects. So where do we use these? Typically for hormone replacement therapy for patients who still have an intact uterus, or more often than not, you can see it used for long-term ovarian suppression. Good for things like endometriosis, or if you have a patient who's using this for contraceptive purposes. They can either be used by themselves or in combination with estrogens. Remember, especially for someone who still has an intact uterus who may become pregnant, estrogens by themselves are not going to be useful or they may be useful, but they're not going to be used because of the risk for endometrial hyperplasia and cancer. But by giving a progesterone, you help to cancel that out. Here, though, you can see you can use a progestin by itself, but we're going to find there's some downsides to that. But a really good example of one is the Depo shot, or Depo-Provera, right? Remember, when you think Depo, you think about holding on to a lot of stuff like the Home Depot, has a lot of stuff all there at the same place. Well, this does the same thing, and it's essentially just a shot you can give that would allow you to have contraceptive purposes or ovarian suppression for about 90 days or so. So this can be useful if you have patients who may be like a compliance risk, for instance. Some of the downsides you're going to see, though, is that it does lead to prolonged anovulation and amenorrhea. So this is not great if you have patients who maybe want to get pregnant soon, or they have a certain schedule in mind, because using progestins only usually have a delayed return to ovulation as compared to using a combination of estrogen and progesterone. So other things you may see some increases in blood pressure, but that really depends on the particular progestin you're dealing with, and those androgenic activity may have some lowering of the HDL you might find. So getting into the specifics of things like hormone replacement therapy here. So again, the reasons why we do this is mainly to treat some of the more moderate to severe vasomotor symptoms like the hot flashes. We use this to treat the symptoms of vaginal atrophy, including like kind of that dryness and that dyspareunia that can happen there. And we also can use it for prevention of osteoporosis. So how you can use this, right? So there's a few different ways. I'm not going to, show you every single product that's out there and expect you to memorize them, but I want you to kind of understand how we're using them, kind of the broad strokes of it. So for instance here, by using combination therapy of estrogen and progestin, this is going to be in patients who still have an intact uterus, right? And so they could either get an estrogen plus a progestin every single day to where they have no withdrawal bleeding. That's possible. That doesn't really, you don't have to have that withdrawal bleeding. Or what you may find is that you'll have, say, estrogens on day 1 through 25, then you'll kick in a progestin on day 10 through 14, and maybe then they're going to be drug-free on 26 to 30, right? Just to give you some different examples of how these may be used. Estrogen only is going to be in patients who have had a hysterectomy, not worried about that endometrial hyperplasia, and this can either be used continuously or in a cyclic manner, kind of what we saw above. And I'll show you some product examples of what this looks like. Typically, though, when you're doing hormone replacement therapy, the doses are physiologic, meaning it doesn't really take a whole lot to replace what these patients are missing, versus using a oral contraceptive. When you're using oral contraceptives, you're trying to shut that ovarian function down as best you can, and so you're using much higher doses, like 4 to 6 times the physiologic effects. Don't get hung up on looking at the comparative doses, though, because you can find these products will have varying potencies at the receptor, such that some of these are dosed in micrograms, some of these are dosed in milligrams, so don't get too hung up on that. Just know that things that are being used for hormone replacement therapy are much lower doses than what you would see with, say, a contraceptive product. So as I mentioned, using oral dosage forms are going to have a lot more first pass effect, meaning you're going to have more stimulation of hepatic proteins, more clotting factors being produced here. That's one thing to know, right? Transdermal products are going to be better for patients who maybe have like a history of hypertension, maybe they have lipid profile issues that you don't want to exacerbate by using an oral product, or if they're at risk for things like VTE and cholelithiasis, because you do miss a lot of the hepatic effects by using a transdermal product. And then intravaginal is going to only really be used for things that are basically kind of working very locally. So they're just having vaginal symptoms. Still get some systemic absorption because, again, it's the thin mucous membrane that's very highly vascular. Yeah, you're going to get some systemic effects, but it's going to be much mitigated as compared to using like an oral product or an injectable. So it's good from that standpoint, but you're going to find the intravaginal is better for mainly just presenting vaginal symptoms there. And then you can have some dosage forms that help to even mitigate that further from a systemic standpoint. So it's like vaginal tablets or rings may be used in some patients. So I'm giving you a couple of slides here of just different products you might expect to see. So for instance, if you're using an oral estrogen only, you can see how these can be given at varying dosages, right? So you want to always make sure you're using the lowest dose possible as you can. These would all be a continuous based product, right? Because you're not seeing any changes in the dose that they're administering there. So that's one thing to note, versus if you're to see like some cyclic ones, which are going to have some withdrawal periods you may see there. Here's an example of some transdermal products you may be administering. Notice here, these can be useful from a compliance standpoint because some of these are either given just like twice a week or just once a week. So it may be better for older patients who may have memory impairment, right? Maybe one thing to note. For some of the vaginal products here, you can notice that while the doses do look quite high, that's actually the amount of cream or ointment this is being administered. So for instance, here you can see with this one, this Premarin vaginal cream, it says 0.5 to 2 grams a day. That sounds like quite a bit, especially compared to, say, something like 0.025 milligrams, right? That's 25 micrograms of estrogen per day. But what you see here is actually equivalent to 0.625, which is pretty similar to some of the oral estrogen products we saw there, like Premarin. Again, here's an example of what it looks like for like cyclic dosing. So for instance here, for using for atrophic vaginitis, you can use it basically for 21 days and then you're off for 7, right? So it just depends on the product and kind of what's going to help to mainly manage their particular symptoms that they're having. Here's an example of a few different rings that can be administered intravaginally, and basically they'd be placed next to the cervix, and they can just slowly release drug over a period of time. Here's an example of an E-string, which is used for 90 days at a time, which is nice, again, from a compliance standpoint. Here's an example of a tablet. Note here the rings in the tablets are designed to get lesser systemic exposure. So if you did not want to get a lot of systemic effects, the patient's just having vaginal issues, then these might be the best products to use for them. Here's some examples of what these products would look like. Note here as well that with things like premium creams, are going to have an applicator to make sure that you can go ahead and measure up the right dose and administer intravaginally. Note here you want to make sure patients are getting educated to clean their products here, because you don't want them to potentially get like a UTI or a yeast infection or something like that, secondary to using contaminated product. Here's an example what the vaginal ring looks like. You can notice here they can just be placed right up next to the cervix, and if it does come out, they can just put it back in. That's pretty easy, kind of no muss, no fuss kind of dosage form. So here's some examples of combination products containing an estrogen plus a progestin of varying types. Again, you can see these may be used continuously or they may be used cyclically. Here's an example of one where you're using estrogen alone on days 1 through 14, and then you're using estrogen plus progestin on 15 through 28 in order to somewhat mimic a normal sort of cycle there. Here's an oral continuous combined where they're just using the same dosage form every single day. There's no withdrawal period there. So for hormone replacement therapy, they don't have to have any kind of withdrawal bleeding. It's just not necessary for these patients here, because the progestin is keeping the endometrial tissue in check because it's opposing the effects of the estrogen, right? Just some other examples here of different products, and notice here that you're going to find much more variability in terms of the progestin that's being given, and so you can kind of switch out and see which one works best for the patient. Some of these are going to have more androgenic effects, some are going to have more mineralocorticoid effects. You kind of have to play around with it to see what your patient responds best to in terms of their weight and things like that. If you have a patient with CHF, I'm giving a product that has high mineralocorticoid effects, that's not going to be great because it's going to be opposing the effects of things like Lasix and other diuretics the patient might be on, for instance. And then here may be an example of just a progestin only. I'd probably see this being used less frequently for hormone replacement therapy because typically they're missing estrogen. That's kind of what they need. But here's just an example of one that may be given, just medroxyprogesterone by itself. So other things we can use, so maybe we have a patient who has a contraindication to receiving an estrogen product. Is there anything we can do to help with his vasomotor symptoms? And a lot of these may look familiar to you if you remember talking about treatment of neuropathic pain, and it seems like these may be able to help in some of those cases there. So things like SSRIs, SNRIs like venlafaxine can be useful here. Even gabapentin and clonidine have been tried previously. So again, a lot of bleed over in terms of some of these medications that are kind of pulling double duty. If I have someone who's hypertensive and they're having hot flashes, well, maybe clonidine can help out and kind of kill two birds with one stone, so to speak. If they have depression or anxiety, like using an SSRI may be able to help both of these issues. So it just depends on the patient, kind of see kind of what they're on, what their comorbidities are, and see if you can kind of try to double up on anything. So then switching gears and going to the oral contraceptives, here you're going to find that when I talk about the monophasic versus bi versus triphasic, essentially this just means how many dosage changes occur throughout the 28-day cycle. You're going to find here that for triphasic, this is where you have at least 2 changes versus biphasic is just 1. Monophasic is just the same amount of the drug throughout the entire period there, right? So we'll look at some examples of what these look like in just a little bit. I'll go to post up a PDF that also has a myriad of different oral contraceptive products that are out there, just so you can see the baffling number of how many there are, but overall you're going to see that they have pretty similar characteristics in terms of how they're being dosed and different kind of broad strokes you're going to see with them, so we'll look at that later. And there's continuous progestin only therapy. Again, we'll look at some downsides to that in just a little bit, but this could be useful if they have a patient who maybe is contraindicated from receiving an estrogen. So again, we talked about their mechanism already, but in addition to helping to suppress ovarian function, we're going to see some other things that happen as well, including things that make it sort of inhospitable for a sperm to kind of come in and fertilize an egg. So you can see things like changes in cervical mucus, you can see things like decreased motility and secretion in the uterine tubes. And so overall, you're going to see that it basically just decreases the likelihood. Now again, I'm not saying that's an absolute slam dunk 100% that everyone's going to have good suppression of ovarian function and not going to have conception, because again, everything can fail, right? But it's very unlikely, right? You'll notice that progestins alone don't always inhibit ovulation, but they do a lot of these other things that help make it sort of inhospitable for a sperm to come in and cause fertilization to happen. So it's one of those things you'll see with that. And that is also going to lead into a lot of the changes, some of the side effects we're going to see with progestins, like abnormal bleeding and whatnot. So again, we're going to see that what we expect to see is some depression of ovarian function. They even tend to atrophy during therapy, just like you would see with exogenous testosterone administration in patients. And most patients will return to sort of a normal menstrual cycle as soon as they come off of it. So within the first month or so, they should be back to normal, about 3/4 of patients, but some may remain amenorrheic and may not ovulate for many months. It just depends on the patient there, but most do. Also, you're going to see in terms of the uterus, you'll develop some hypertrophy there. You're going to notice some thicker, less copious mucus. Again, it's going to make it more difficult for sperm to come in and do its work. In terms of breast effects, you usually expect to see enlargement and also suppression of lactation. Tend to see that we're going to have suppression of things like prolactin when you have excess estrogen coming on board here. And then the hematologic effects are the big thing that we worry about, especially from like an emergency medicine standpoint, because classically you always think about like a young lady comes in with chest pain, shortness of breath, history of being on oral contraceptives. Like, yeah, you got to worry about a PE, right? So this really has to do with a lot of the liver effects you're going to see with these oral contraceptives, causing increases in your clotting factors and overall decreasing antithrombin 3 activity. Again, we mentioned the hyperpigmentation effects you can see here, typically more often with darker complexions, can be somewhat reversible with time once they're off of the medication there. And then note that the androgen effects, maybe from the estrogen a little bit itself, but also from the progestins, can worsen acne for some patients. You'll find that sometimes hormonal contraceptives can help treat acne, but for some patients, the androgenic effects are too strong. They can worsen it for them. So again, it's sometimes to play around to find out what works for your patient. So as again, we mentioned that with contraception, this is kind of the most common use for these type of products here. They say that the risk for actual having a failure in pregnancy is quite low. So if you had perfect use, meaning that a person used it exact same time every single day, no missed doses, they would expect to see between 0.5 and 1 pregnancies per 100 woman years, right? So if you had one woman, you followed her for 100 years, or you had 10 women, you followed them for 10 years, you'd have between half and 1 pregnancy. I don't know what half a pregnancy looks like. I don't know if it's the left side or the right side of the baby, who can say. But typical use, given that humans are humans and we err, right? So you can see that they have about 5 to 12 pregnancies. So again, these are not foolproof. These are not 100% guarantee patients aren't going to get pregnant. So make sure patients are aware of that, because you don't want them to come back being mad at you saying like, hey, I was using it like I was supposed to, but I got pregnant. Like, well, maybe they missed a dose, or maybe something happened, maybe it could be a million different things happening there, right? Consider though, drug interactions, right? They could affect things. So for instance, if you had something like a CYP3A4 inducer, like phenytoin on board, that can then help to enhance metabolism of the drug, leading to a shorter half-life, meaning you may not have enough estrogen around to cause sufficient ovarian suppression, right? So a lot of different things that could be playing a role here. We can also use this for things like endometriosis. Using those extra estrogens help to shut down that LH and FSH release, which helps to kind of alleviate pain for those patients there. And again, try to use lowest doses wherever possible for these to help mitigate some of those side effects. In terms of other mild effects, these are pretty similar to what we saw with the use for hormonal replacement therapy, so I don't need to go over each one of these again. But you will see things like mastalgia and breakthrough bleeding. A lot of this tends to be used due to having too much estrogen. So again, you can kind of play around the dose and find out what's going to work best for your patient there. In terms of withdrawal bleeding, it may not always happen for patients here, and this is why, again, when we first prescribe it, it's usually for 3 months at a time, because some of these side effects tend to go away as the body sort of gets used to it. Some of them will not, and that gives you time to at least figure out which one's which. And so, for instance, having a failure to withdrawal bleed can be problematic, because patients may think, hey, I didn't bleed, I might be pregnant, right? And they may freak out. So again, we'll talk about ways to mitigate some of these issues in just a little bit. In terms of moderate effects, you may see some weight gain, may see breakthrough bleeding. Some of it depends on the doses you're receiving there. Sometimes it depends if you're on like a monophasic product and or using a bi or triphasic product. So again, where you're kind of shifting the hormones around to can have some effects there. So these are things you may want to consider, and I'll kind of go through that chart in just a little bit and explain that to you. In terms of weight gain, you're more likely to see this with androgenic like progestins, and then also things that have kind of strong mineralocorticoid effects. And so you can either try switching over to one that does not have as strong of that effect, or maybe trying changing things like diet and salt restriction and things like that may help out. We mentioned the increase in pigmentation. Again, you may find that this is problematic for patients, especially depending on what their complexion is to begin with. It is reversible, but it tends to be slow. And as long as they're on the drug, they're going to find that hyperpigmentation is still there. So it would be something they have to switch over to a whole another product completely. And then I mentioned the androgen tends to be more related to the androgen-like progestins, whereas large dose estrogens themselves may actually help to improve acne by overall shutting down the body's own androgen production. Hirsutism can happen here, again, more related to the progestin that you're using. So that's something we're going to look at a little bit later on with a chart to kind of show you which ones tend to be more likely to cause some of these side effects than others. Vaginal infections can be more likely due to some things like ureteral dilation and basically things that are making it, making changes in mucus secretion and things like that to make it more hospitable to bacteria, unfortunately, and things like that. So that is a risk you can see with that. And then again, amenorrhea may be a possibility here for some patients, especially that menstrual irregularities prior to taking these drugs here. This tends to be more likely in those patients, and some of it may be related to things like having a prolactinoma that was undiagnosed previously. So that's one thing to note. Obviously, the really severe risk is the thromboembolism, either VTEs or PEs potentially. And as soon as you're on the medication, you're going to be at risk. And as soon as you come off of it, you're going to go down back to baseline risk, essentially, mainly because it's the estrogen specifically affecting the liver, causing an increase in clotting factors and things like that. So it's one thing to note. If you had someone who could not receive an estrogen-based product because of this risk for VTE, you can use a progestin on its own. That's totally fine. It's just the estrogen that's really the one causing the risk here. To go along with that, things like risk for MIs, especially if they have high risk factors beforehand, especially if they're a smoker. So these are all things you want to definitely educate on. Some good lifestyle changes to make may be able to help mitigate these risks. So VTE or cerebrovascular accidents are another possibility. The gastrointestinal effects, again, more seen with the oral products. You see things like cholestatic jaundice. Again, typically you're going to see this more often in like the first 3 cycles or so, and it usually should resolve over some time. However, if it's going to be enough to discontinue the use altogether, it usually takes between 1 to 8 weeks for the jaundice and pruritus to kind of fully resolve on its own. You may find that mood may change for some patients. Depression may be exacerbated, so some small number of patients will require discontinuation. Again, you can try switching on to different products. You may find some work better or worse for them. It just depends. Looking at the risk for cancer, you tend to find that depending on the cancer you're looking at can have different effects. So for instance, having lifetime breast cancer risk does not appear to be all that strongly affected, at least as far as we can tell, versus using combination progestin therapy may help to reduce your risk for ovarian cancer, for instance. So really just depends on the type of cancer you're dealing with. Again, you're not going to use this specifically for preventing cancer, but this is a risk you would know about. Here's a good table kind of comparing the different effects of the different progestins. You can see here kind of going from the first generation all the way down. We get more specific for having stronger progestinal effects while losing some of the ancillary effects we care about. And namely, it's mostly the androgenic effects we worry about in terms of causing things like hirsutism and whatnot. And so again, it's gonna be more mitigated by getting down to these kind of 3rd to 4th generation agents here. And again, don't memorize which ones have 3 to 4 pluses on here, but kind of know in general which ones are really strongly androgenic ones versus ones that are more weak. Ones that have kind of strong estrogenic effects versus ones that are weak. Things like that can be useful. So in terms of contraindications, a lot of these are similar to what we saw before for hormonal replacement therapy. Obviously, if they have any estrogen-dependent tumors or unknown causes for bleeding, anything like that. Typically, we don't like to use these for adolescents who haven't undergone epiphyseal closure, because this can lead to premature closure and can lead to stunted stature potentially. So that's one thing to note. You want to be careful if a patient's on a hepatic enzyme inducer, because that can then reduce the level of the drug. The estrogen can lead to ovulations that could be due to a therapeutic failure. Obviously, they're pregnant, they don't need to be on hormonal contraceptives. And the antibacterials is one that is controversial. There's probably no good clinical evidence to say not to administer these two together or to use backup prophylaxis. But again, we worry about this antibiotics decreasing the gut flora, causing a disruption of that enterohepatic recirculation. So that's a reason why you're concerned about using backup or extra prophylaxis while on antibiotics. But again, it's good, safe, kind of low risk sort of intervention there versus the risk of if you get accidentally pregnant, that's not great, right? So progestin-only contraception is going to be better for patients who cannot receive an estrogen by itself. It's not nearly as effective, and in fact, you'll find the failure rate's going to be much higher than if you're using a combination of the two products there. And you do tend to find higher incidences of abnormal bleeding. So amenorrhea is common, and also you're going to find a big delay in return to ovulation. Especially if you're using a depot shot that lasts for 90 days or so, or is administered every 90 days, it doesn't just stop working at day 91, right? It actually can have lasting effects for several months even after that. And so that's why if you have someone who is like, pretty determined, I want to get pregnant around this time, progestin only are not going to be good ones to use because they may have delayed return to ovulation, maybe up to a year or longer potentially. So in terms of postcoital contraceptives, these can be useful for helping preventing, say you have a case of unprotected sex that occurs, patient was not on any kind of prophylaxis, and they need something to help make sure that no pregnancy actually takes place here. These are your morning after pills. These are typically either estrogen-based, progestin, or they could be a combination of the two. And in fact, there are certain dosing strategies where if a patient does have access to their birth control, they can take a larger dose than usual, which I'm not going to get too into the weeds on here. But just to give you an example, something like levonorgestrel or Plan B, that's usually the most common one people think about. Here, note it's just a progestin by itself, and you just give a one-time daily dose, for example here. This helps with compliance, right? Big problem though is that you have to think about the timing and you also have to think about the side effects. So for instance, you have to make sure that patients are getting within 72 hours because after that, the risk for failure drops off pretty significantly. If you use it within that time frame, 98% effective. So that's really nice from that standpoint. However, patients are going to have a high risk of nausea and vomiting associated with these because again, we're giving a much larger dose for this one-time deal than we would say for typical hormonal contraception every single day. So nausea vomiting is really a high risk, and so you want to make sure that if they are at risk for that, then they go ahead and take an antiemetic. Otherwise, if they say just go down to Walgreens because they can get one of these without a prescription, they take it and they throw it within the hour, they probably need to redose. That hour mark is kind of the time frame I usually use. If they throw it within an hour, have them redose. If not, then they should be okay. If it was say 2 hours later, should be fine. So other beneficial effects you can get from these products here, including decreased risk of things like ectopic pregnancy, iron deficiencies, maybe you're helping to reduce bleeding potentially, acne, hirsutism, just depends on, again, the progestin they're also receiving as well, because some of these things could be worsened, things like the acne and the hirsutism. So that's one thing to note. So it depends on the product you're using. Not every patient will get these same benefits. So in terms of like how you want to start these patients, typically you want to start with a combination pill as long as there's no obvious contraindication to receiving estrogen. And you typically want to use the lowest effective dose. Most products are going to be ethinyl estradiol, so it'll be pretty standard for most products there. And basically you want to kind of figure out what the acceptable level of side effects is going to be and kind of talk to your patient, let them know what the common things are and things they can expect to get better or things to maybe not change over the period of time. And usually you give them 3 months supply to see how they're going to respond to it. Typically, they recommend starting the first Sunday after the onset of menses. The reason for that is that Sunday is a magical day, and I'm just kidding. There's no magic to this. The idea, though, is that if you're likely to have withdrawal bleeding, it would not occur on the weekends, essentially, because it's assuming people are going to be active and going out and doing things, having fun on the weekends, and they probably don't want to be bleeding during that time frame. So that's why they recommend starting on a Sunday, so that way you have your withdrawal bleeding usually during the early parts of the week, right? So if it's post-pregnancy, they usually recommend restarting on contraception around 3 to 4 weeks post-delivery there. And then if you had an abortion, you can go ahead and start the first Sunday after that abortion. It's perfectly reasonable to start then. Now, in terms of like recommending using alternative forms of birth control in addition to the oral contraceptives, like using like a backup like prophylaxis, like condom and things like that. People say during the initial cycle while they're on it, they may not get full protection, even though it's kind of controversial. But again, it's a low risk recommendation. Most patients might not even follow it anyway, depending on what their situation is, so it just depends. We'll talk about missing pills. We're going to find that the lower the dose of estrogen they're on, the more likely they are to develop failure, and so we'll talk about what to do with missed pills in just a moment. Severe diarrhea, because maybe if they're interrupting the enterohepatic recycling because they are basically expelling their GI contents too quickly. That could be one thing you may want to consider using a backup form of birth control. And then antibiotics as well as another controversial one, but again, low risk thing to recommend. So what to do if you miss a pill? If you just have a single missed pill, usually just recommend taking it as soon as it's remembered, especially if it's the same date, no big deal. The timing is not nearly as critical based on the long duration of action of these drugs here. If it's two pills, typically I recommend taking 2 a day for 2 days to get them back on track. That's totally reasonable. But if it's 3 or more, they do recommend go ahead and discontinuing the rest of the pills and just restart on a new Sunday. Okay. With progestin only products, the risk for failure is much higher, especially if you miss a dose. And so those you have to be much more, very regimented about taking the same time every single day to make sure they're not going to run into any issues. Obviously, that's obviated if you have the injection because it's long acting; it's always there. But yeah, if it's progestin only, then if they miss a pill, I would definitely be really recommending they use backup prophylaxis just because their risk for failure is much higher. So if they have a missed period after the first cycle of a new product and they say they missed no pills, I probably wouldn't jump to getting a pregnancy test. They might do it anyway just from anxiety's sake, but if it's after the next cycle and they're still missing one, I would probably go ahead and check it at that point. If you want to reschedule the menstrual cycle, which is something that I had no idea you could do until I was in pharmacy school, and I thought, wow, this must be some form of magic or something, but there's ways you can reschedule the menstrual cycle, right? So as long as you're taking continuous active pills and you don't get down to those placebo pills at the end of a pack, you never have those withdrawal bleeding, which makes total sense because that HPA axis is still suppressed. You don't have the withdrawal estrogen effects. You never slough off all that endometrial tissue, right? So basically what's going to happen here is if they have an event coming up, say you want to get married and they're going on a honeymoon, or they had something coming up but they did not want to be on their period, basically if you can go ahead and continue having active drug being given, so maybe skipping the placebo pills for a pack and then starting up a new pack immediately, that will help them to reschedule that. And then when they come back from whatever event, they can just go ahead and say stop on a typical whenever, have their withdrawal period, and then they can start back on the next Sunday. So again, nothing special about that. And again, there are even certain birth control products, which I'll show you in a little bit, that are just continuously active drug for say 3 months at a time, and then basically only have 4 periods in a year. So as long as you're giving continuously active drug, they will not have withdrawal bleeding for the most part. So in terms of like stopping pills, like there's no need for like rest periods. There's no need to undergo like drug holidays or anything like that. But if a patient is desiring to get pregnant and they're coming off their medication, you want to make sure at least give them a decent time frame. So let them know it may not be the first cycle. It may take a few cycles prior to them actually getting pregnant again. So it may take some time depending on the patient and what product they're on. In terms of breakthrough bleeding, if it's during the first 3 months, it takes time for the body to get used to this new kind of normal in terms of hormonal effects. So this generally resolves over that time frame. If it's still present, it may be related to the dose of medication giving a certain part of the cycle there. So for instance, if it's bleeding on the first 2 weeks or so, it's usually going to be related to an estrogen deficiency. So you could try changing the dose rate, kind of bump that up in the early parts of the cycle there. So for instance, if you're on a triphasic that starts with a really low dose in the beginning, maybe switch to a biphasic that has a little bit higher estrogen content in the very first part of the cycle. If it's bleeding on days, say 15 through 21, that usually indicates a progestin deficiency. So maybe either changing out the progestin product itself or maybe bumping up to a bigger dose can help out with that. I mentioned medroxyprogesterone or the Depo-Provera. Again, this is something given every 3 months, but just note here that the duration of effect can be 4 to 6 weeks, even longer than that 3-month period. So great if you have a patient who you really are worried about from a compliance standpoint, worried about them not following up. They're at least protected for a little bit longer than that. But note that again, you're going to have delay in return to ovulation. You're also going to have pretty irregular menstrual bleeding pattern. So amenorrhea is quite common for these products here. So just one thing to note. Now, here's a couple of different products here you can use that will provide medication kind of directly in the area where it need be. And notice here, these drugs are working locally. They're not going to cause suppression of ovulation from a central standpoint, from the hypothalamus and the pituitary sort of standpoint. But here's an example, one called levonorgestrel or Mirena, where basically the drug itself has been, no pun intended, impregnated into the actual product that slowly leaches out over the course of 5 years or so. And note here, basically the provider would have to go in and place this. There is some risk associated with these, and usually docs will have the patient come back in to make sure, because there is a risk for translocation of these, where they basically get embedded into the lining of the uterus and get translocate out into the abdominal cavity, which is obviously sounds scary, but is rare, but I still like to check on that sort of thing. But you notice the strings here that can be then used to remove them later on. And again, you get mostly local effects. There's still some systemic absorption, but you can see here that it helps to mitigate some of those more systemic effects, like things like estrogen effects, right? So you're not worried about estrogen effects in the liver because this is just a progestin releasing on its own. Note the things you're going to cause here, including basically it's just not really hospitable for sperm to come in and actually cause a pregnancy to occur here. And so again, you're going to see things like thickened cervical mucus, and basically the uterine lining is going to be pretty thin. It's just not really all that hospitable to an incoming sperm to fertilize that egg. Here's some other examples. Here's in a combination estrogen and progestin called the Nuva ring, where basically this will be placed intravaginally, and it allows for 3 weeks in, 1 week out, to again get kind of typical sort of withdrawal bleeding effects there right at the tissue. Here's an example of one that's another implant you can actually give that would have to be given in the office. Implanted in. This one is changed every 3 years, right? Note here for some of these though, you're going to get some irregular bleeding, mainly due to the effects that it's going to have on the more systemic effects you're going to see with something like this versus something that's just placed into the uterus itself. Here's an example of one that is non-hormonal altogether, which is kind of nice if you had someone who is at risk or they're really kind of hesitant to use hormones. This one is actually going to be called Paragard, which is a copper contraceptive. And so this actually slowly releases copper ions that helps to impair implantation and basically movement and fertilization of the sperm. And the duration of action for this is something like 10 years, which is really kind of wild when you think about, you know, hey, you kind of set it and forget it, and then you don't have to think about it for many years. And again, as soon as the product is removed, things kind of go back to normal pretty quickly if the patient, say, for instance, did want to get pregnant again. So just to finish things up, talking about some inhibitors and antagonists. So again, there's different ways we can affect the system here in terms of decreasing either estrogen production from several different steps. And we're going to look at a few of these here, including some GnRH agonists, getting down to some aromatase inhibitors and whatnot. So to talk about our selective estrogen receptor modulators, the first one we had was tamoxifen or Nolvadex, and basically it worked as you know, an agonist in the bone and the endometrium, but it was an antagonist in the breast tissue. So it was originally used for patients who were like high risk for breast cancer based on family history and things like that. And again, we just know that it worked as an agonist in some tissues, antagonist as others. This one's not great from a side effect profile because overall you're going to see decreased estrogen activity because of its antagonistic effects, which means you can induce menopausal symptoms like hot flashes and vomiting. So this one's not super you know, well liked because of the risk you're going to see in terms of side effects, but you will find that it's going to have, you know, nice effects on the bone here, right? So it helps to prevent things like lumbar spine bone density or loss of that spine density, right? You can also see that due to its partial agonist activity there was risk for endometrial cancer and vaginal bleeding, because we did see it was a partial agonist there, and risk for thromboembolism. So not a great drug, usually used as like a backup if other agents have failed, or if perhaps patients have had a hysterectomy and not worried about the endometrial cancer risk, you know, things like that. Some other agents here include things like raloxifene, which is going to be nicer in the side effect profile, mainly because it does not stimulate the endometrium or the breast tissue, so good for that. And it does still have positive effects on the lipids profile and on the bone as well. And so again, typically used for like either prevention of osteoporosis or maybe for like high-risk breast cancer in certain women, right? Another one that's a partial agonist is going to be clomiphene or Clomid. This one's kind of interesting because it actually helps to work in the hypothalamus, and it actually helps to disrupt the negative feedback loop. And so this one is actually used to stimulate ovulation instead of inhibiting it like you'd see with something like, you know, ethinyl estradiol or something like that. So this is the common thing you'll see being used for people who are having trouble conceiving, to try to help kind of kick over the ovulation process over again. Some antagonists we have here include things like danazol, which is going to be basically suppressing ovarian function by helping to inhibit that mid-cycle surge of LH and FSH, and is useful for patients to treat things like endometriosis, where overall you don't want the ovaries to be kind of working too much. I see this used occasionally in some other conditions, some hematologic issues like hemophilia, but this is usually second or third line kind of agents here. And typically you're going to find a lot of the effects, the side effects are going to be related to some of these kind of additional ancillary effects like androgenic issues, glucocorticoid effects. So you can see things like decrease in breast size due to overall estrogen activity. You can see weight gain and edema, deepening of the voice, and hirsutism. So again, not great from a side effect profile, but typically used as a sort of backup if some of the other agents have not been working. In terms of aromatase inhibitors, there's kind of varying degrees of how well we can inhibit aromatase. Obviously, if it's an irreversible inhibitor, it's going to be much stronger, and overall you're going to see much bigger reductions in estrogen levels. These can be really bad from a side effect profile because this is essentially like putting your patient into menopause. Not only that, but also the risk for fractures is really high here as well. And this is why we typically use them if, say, for instance, patients are maybe resistant to something like tamoxifen or the other SERMs are not going to be good options. These may be used as a kind of a backup to that. So that's it for this section. If you have any questions, certainly let me know. That was actually it, I think, for all the material for this class. So it's been a long year, but hopefully you guys have learned something. And I will see you all very soon. So thanks a lot. Bye.